Good afternoon, everyone. I'll be talking about CACXL and keratoconus in thin corneas. So I have no financial disclosures here. So coming to the role of cross-linking in keratoconus, it's now known that the linking that is inherently weak in keratoconus, conventional cross-linking has shown to make the cornea nearly 300 times stiffer. So this effectively adverts the need for a transplant, or if at all it delays the transplant. And now it is also known that it is visually rehabilitative in the fact that it causes flattening in the long term, and it can be combined with other procedures like CARES and intracorneal ring segments. So essentially the role of riboflavin is it absorbs the UV light, acts as a photosynthesizer, and it promotes cross-linking reaction. It also absorbs UV light so that the endothelium lens and the retina are protected from the toxic side effects of UV light. So when do we cross-link? When do we cross-link? So when ideally when we see progression in the keratoconus, so the criteria are written there. Manifest refraction increasing more than 1 diopter per year, Kmax more than 1 diopter per year, Kmax minus Kmin more than 1 diopter increase per year, then 2% decrease in the central corneal thickness, increase in the central K power more than 1.5 from baseline per year, and manifest cylinder increase more than 0.5 diopter per year. When do we link earlier? Sometimes when we see a young patient less than 14 years, we know that this is a progressive disease, so we do cross-link earlier. Above 8 years is above 8 years you can cross-link corneas, though US FDA doesn't allow cross-linking below 14 years. Other studies have shown that children above 8 years, when cross-linked earlier, there's a better stabilization of the disease. Pachymetry less than 425 microns because there is very little window space for you to go for a standard cross-linking. Documented progression, of course. Family history of keratoconus with progression. Patients who have associated severe allergy because they tend to rub the eyes and the progression is faster. And if a patient has other eye drops or we see a possibility of loss to follow up in such patients, we opt for an earlier cross-link. So we have a CXL treatment algorithm. I'll just go to the thinner corneas. So what is the issue with thinner corneas? Penetrance of UVA is up to anterior 300 microns of de-epithelialized cornea. So whenever we land up in a situation where we know that after removing epithelium, we don't have sufficient stroma left, that is when we have to think of other alternatives to the standard cross-linking. If the de-epithelialized cornea is too thin below 400 microns, there is a chance for UVA toxicity to the underlying endothelium lens and macula. And in this case, if we keep the UV radiation too superficial, then the depth of the cross-linking wouldn't achieve enough corneal rigidity, so the purpose would be defeated. So in a CACXL, that is a contact lens assisted cross-linking, this complex provides an extra buffer of about 107 to 110 microns to prevent deeper UVA penetration. So that is how we prevent toxicity to the endothelium. But does this suffice to give the cornea enough strength, rigidity in future? That is to be seen. So let's take few scenes where we have the minimum Pachy falling about 420, 430. So we know if we remove the epithelium, let's remove say about 55 microns, we are left with sub 400 level thickness of stroma. So these are the situations where standard CXL would not work. In these cases, we have to think of other alternatives. So what are the other alternatives that are known? One is use of hypotonic riboflavin, transepithelial cross-linking, then contact lens associated assisted cross-linking, smile lenticule assisted cross-linking. So these have all been tried. So this is the algorithm for contact lens assisted. If Pachy is more than 400 microns after removing epithelium, we can go for a conventional CXL. But if the Pachy falls short of 400 microns, Then we, after removal of epithelium, then we have to think of a contact lens. So then we take up these patients for contact lens assisted cross-linking. So after applying intraoperative pachymetry is a must. If after applying riboflavin for more than 30 minutes, we see that the pachymetry is above 400 microns, we go ahead with the cross-linking. If we see that it is slightly short of 400 microns, that is with the contact lens complex, then we can add a little of distilled water at 10 minutes interval so that we attain a thickness of 400 microns of the whole complex. So what are the disadvantages in the other methods? That endothelial cell loss in conventional and 0.1 hypoosmolar riboflavin use was seen. Transient swelling of stroma and thinnest pachy falling below, significantly below after 10 to 30 minutes of dextran based riboflavin application. So while we are cross-linking, the thickness that we have achieved before cross-linking, that falls drastically. In transepithelial cross-linking, we do not achieve that much amount of stiffness. The contact lens riboflavin complex, we get an extra buffer of 107 to 110 microns. So essentially the process is the same, except that while we are applying drops on the cornea, riboflavin drops on the cornea, simultaneously we have soaked non-UV barrier free contact lens in riboflavin solution. So this is also soaked for 30 minutes. Intraoperative pachy is always a must. And then before we start cross-linking, this riboflavin soaked contact lens is placed on the cornea, and then it is exposed to UV light for 20 minutes as opposed to 30 minutes for standard cross-linking. At the end of the procedure, it's washed thoroughly, bandaged contact lens is placed, antibiotic eye drops applied, and the standard post-operative regime is the same. Topical antibiotics till defect heals. So we have in our case, we had a case series where we took up 30 cases, and the results. Can I take 1 minute, half minute? It's up. Okay. So in our case series of 30 patients, we achieved, none of the patients showed progression at the end of 1 year, and subsequently they have been followed up for more than 3 to 5 years. None of them have shown any progression. Immediate post-operatively also all were doing good, except 3 cases which had persistent haze that took an extra month to be reversed medically. So in conclusion, it's a contact lens assisted corneal collagen cross-linking is a safe technique that offers promising results in the management of patients with progressive keratoconus and thinner pachymetry values which are not amenable to treatment by the standard procedure. Thank you.
Thank you. Any questions?
No.
Our moderator, would you like to say something? Please.
We have Dr. John here. Dr. John, any inputs or any comments?
It was a nice presentation, sir. So basically, ma'am, I am using the HPMC, ma'am.
Yeah, we use HPMC or isoosmolar, not dextran.
Presently, actually, I combine the thing in epi on and epi off. So, yeah. So I have done a series of patients, ma'am. I presented in the ECRS also. So presently, I am combining the epi on and epi off. And the thing, I just maintain the central islands of the epithelium. The remaining mid periphery, I remove the epithelium. So one advantage, adding advantage is that is a modification of the HPMC1. So central, as a central epithelium intact, so next morning the patient having the central visual intact, patient symptomatically better, and the early healing will be there. So I didn't put on even also BCLs. Within 24 to 40 hours, the epithelium regenerated, and we have done the statistical analysis of both the group. Total entire epi off and combined epi off, epi on. Both are showing the same, halting the progression of the statistical one.
What about the ASOCT level of the demarcation line?
Demarcation is same, ma'am. Same.
Like, do you get a flat line or you get the hat on?
Hat on, ma'am.
Hat on line.
Hat on line, ma'am.
Because this way there would be less penetrance in the center.
It is not that center part, there is less penetration than it's not. Because we have earlier this proven factor. For the long run, whenever we have done the combined epi on, epi off, both or more or less both the same, ma'am. Efficacy wise, the efficacy of halting the progression. Main motto is halting the progression, and Even also previous thought process was that even before the 400 we can't go ahead with the procedure. But I have a series of patients, ma'am, we have done the 40, 50 patient, and all having the cutoff value is less than 400.
Okay.
Yeah, thank you, ma'am.